Welcome to the Rad-On Smart Review GU Cancer Series.
Glad to be here for this deep dive.
I want you to imagine staring at a lab result where a single tiny decimal point is literally the difference between reassuring a terrified patient and, well, sending them into a grueling, life-altering salvage surgery.
Right, because on the front end, you draw the contours, you calculate the dose in gray, and your plan shows this beautiful, exact distribution of the beings.
Exactly. You point to the screen, you tell the patient the problem is solved, but then you step into the actual clinical reality of prostate cancer follow-up.
And suddenly that crisp, perfect treatment plan is completely in the rearview mirror.
Yeah, we end up looking at a diagnostic landscape that is, frankly, incredibly murky. I mean, most of the teaching in this field focuses so heavily on the front end.
Oh, absolutely. The risk stratification, the dose, the fractionation schedules, deciding, exactly how many months of ADT to give.
But the reality of clinical practice, and definitely the reality of the board exams, is deeply rooted in the long game.
You're going to spend vastly more time in your career interpreting PSA trends or counseling men about the late effects of the radiation you delivered than you ever spent simulating that original plan.
Right. And the boards love this space precisely because a single follow-up visit tests your judgment on multiple distinct fronts, all at the same time.
So to really ground this whole conversation, we need a longitudinal patient case to anchor us.
Let's do it. Let's look at a 68-year-old man. He is exactly 2.5 years out from definitive external beam radiation, or EBRT.
Okay.
He was treated with moderate hyperfractionation to the prostate and the proximal seminal vesicles for unfavorable intermediate risk disease. So specifically, his Gleason score was 4+3, and his initial PSA was 11.
Right, and that unfavorable intermediate risk dictates that he received hormone therapy along with the radiation.
Exactly. He completed 6 months of ADT.
And over the past 9 months, his testosterone has slowly recovered into the low normal range.
Now, during his time on ADT, his PSA nadir, meaning the absolute lowest point it reached, was undetectable.
Which is what we want to see.
But 6 months after his testosterone finally recovered, his PSA was measured at 0.4. And today it is 1.6.
A PSA that goes from undetectable to 0.4 to 1.6 is, it's going to make any patient and frankly any junior attending start sweating.
Oh, for sure.
Yeah.
But there's more. You're sitting in the room with him, and he casually mentions he's having intermittent, bright red rectal bleeding with his bowel movement.
Oh, boy.
Yeah, maybe 2 to 3 times per week. He also has some urinary frequency, though he says it is manageable.
And let me guess, his erectile function hasn't returned.
Has not returned to his pre-treatment baseline. He is not on any bone health therapy. And to top it all off, you open the chart, and the urology note from his referring doctor just simply reads,
Let me guess. Rising PSA, please evaluate for recurrence.
spot on.
It's the classic, terrifying one-liner from urology. I mean, look, we have 3 major clinical domains crashing together at once here. We have a highly concerning PSA trend, we have late GI toxicity with that rectal bleeding, and we have a whole host of survivorship items
Bone health, metabolic health, sexual health.
that clearly were never properly owned by anyone on his care team. If you are taking your oral boards or presenting this case in clinic, you need to sound like someone who sees the whole chessboard.
So how do you frame this exact patient out loud for an examiner? Like, what is the 60-second script that synthesizes all of this?
Well, it sounds something like this. This is a patient with treated unfavorable intermediate risk prostate cancer, 2.5 years out from definitive radiation with short course ADT. He's now presenting with a rising PSA after testosterone recovery, late GI toxicity, and incomplete survivorship follow-up.
Great opening, sets the stage perfectly.
Right, and then I'd say, my first job is to decide whether this represents a benign post-radiation PSA fluctuation or a clinically concerning biochemical recurrence. I'll interpret the rise against his true post-treatment nadir using the Phoenix framework, but I'll carefully evaluate the timing, trajectory, and context of his testosterone recovery, rather than just reacting to one number in isolation.
Which is crucial.
If the rise is confirmed and he is a potential salvage candidate, I would restage him with a PSMA PET scan and a prostate MRI. Furthermore, if local salvage is being actively considered, I would mandate biopsy confirmation, including sampling of suspicious areas and the seminal vesicles.
And for the toxicity.
In parallel, I would address his rectal bleeding as likely late radiation proctitis while ruling out other causes, and I would take ownership of his survivorship, directly addressing his bone, metabolic, cardiovascular, and sexual health.
Boom. I mean, that immediately establishes control.
It really does.
And it transitions us perfectly into looking at what follow-up is actually supposed to achieve. Because, looking at this 68-year-old guy, the overwhelming temptation is to just fixate entirely on that PSA going from zero point 0.4 to 1.6.
Absolutely. The number is the scariest part.
But follow-up is actually a three-pronged mission. Job one is to detect recurrence early enough that a salvage treatment can actually matter.
Right. Job 2 is to detect and manage the late toxicity from the treatment you originally chose.
And job 3 is to handle the ADT survivorship. Let's actually examine that first job, detecting recurrence early.
Because there is this deeply ingrained psychological reflex to over-image in these scenarios.
Oh, 100%. A resident sees a PSA bump up by like a fraction of a point, and their immediate instinct is to order a reflexive PSMA PET scan.
The patient is terrified of dying from cancer, and the clinician is terrified of missing a recurrence.
I always compare that to hitting the panic button on a smoke detector just because someone in the kitchen is making toast.
That is a perfect analogy.
Why is restraint such a difficult clinical skill to learn here? I mean, why do we default to the scan?
Well, I think because it requires unlearning the acute care mindset. For a huge percentage of prostate cancer survivors, particularly those who had lower or intermediate risk disease, the dominant threat to their life and well-being is not actually cancer death.
Right.
The dominant threat is the quality of life toll taken by the treatment itself.
Yeah, we were talking about urinary function, bowel control, sexual function, profound fatigue.
Bone loss, cardiovascular risk. Reflexively ordering a highly sensitive, really expensive scan for every minor fluctuation creates immense psychological anxiety.
And it can lead directly to unnecessary, highly morbid intervention.
Exactly.
So what are we actually measuring when we bring them back into the clinic? I mean, we used to rely heavily on the digital rectal exam, the DRE.
Right. That was the cornerstone of the follow-up visit for decades.
Yeah, its utility has shifted, hasn't it?
It has. The DRE still has historical importance, sure. Feeling a hard nodular recurrence in a previously irradiated gland is meaningful. But the radiation itself causes profound fibrosis.
The tissue literally changes.
Right. The prostate feels different after a definitive dose. It can feel firm or woody just from the treatment alone. So in modern follow-up, the DRE is no longer the main surveillance driver.
So the PSA trends, the symptom patterns, and the context of recent or ongoing ADT are what truly drive the bus.
Exactly. After definitive radiation, the PSA falls very slowly over time.
Right, because the gland is still in the body. I mean, it has been irradiated, the DNA of the cells has been critically damaged, but the physical tissue remains.
It's still there.
So reaching the nadir, the absolute bottom, can take years, especially if ADT was part of the treatment.
You are reading a biological curve over time. You aren't just reacting to a single static data point.
Now contrast that with a patient who underwent a radical prostatectomy.
Oh, after surgery, the biology is entirely different. There is no intact prostate left in the pelvis.
The PSA should drop to undetectable very quickly.
And the threshold for recurrence is drastically lower, which really brings us to the definitions of failure. You have to understand the underlying pathophysiology of what you actually did to the patient.
Yeah, there are two core recurrence definitions, and crossing them up is a fatal flaw in clinical practice. So let's lay them out. After a radical prostatectomy, biochemical recurrence is defined as a PSA of 0.2 nanograms per milliliter or higher, confirmed by a second value.
Right. And after definitive radiation, the standard biochemical failure definition is the Phoenix definition.
Which is?
That is a PSA rise of 2 nanograms per milliliter or more strictly above the nadir. So nadir plus 2.
The conceptual difference there is just stark. A post-prostatectomy PSA is like an on-off switch.
I like that.
The prostate has been physically removed from the pelvis, it is gone. Any PSA signal above that 0.2 threshold is an immediate blaring alarm that prostate cells are producing antigens somewhere they shouldn't be.
Right.
The switch got flipped on.
Right.
But a post-radiation PSA is more like a gliding parachute. You treat the gland, and it takes months, sometimes years, to slowly descend down to its nadir. And sometimes, while it is gliding down, it catches an updraft.
And that updraft is the PSA bounce, which is arguably the single most significant trap in post-radiation follow-up.
Let's define the bounce for the listeners.
A PSA bounce is a temporary benign rise in the PSA level after radiation therapy. We see it incredibly frequently, particularly after brachytherapy, where the radioactive seeds are placed directly into the prostate.
But it certainly happens after external beam radiation as well.
Oh, absolutely.
Let's dig into the biological mechanism of the bounce. I mean, why does the PSA suddenly spike if the cancer isn't actually growing?
Well, the exact mechanism is a subject of ongoing radiobiological debate, but it is heavily linked to the immune system and delayed inflammatory responses.
Okay, break that down.
When you irradiate the prostate, you cause cellular necrosis and apoptosis. This releases tumor antigens into the local microenvironment, which then recruits CD8 positive T cells and macrophages.
So you get this delayed, localized inflammatory storm within the irradiated tissue.
Exactly. The remaining benign glandular tissue gets incredibly inflamed, and inflamed prostate tissue simply leaks PSA into the bloodstream. It is essentially a radiation-induced prostatitis.
Okay, but if it is just inflammation, how do we confidently differentiate it from a true recurrence?
That's the million-dollar question.
Right, because if I have a 65-year-old guy sitting in front of me who is 14 months out from low-dose rate, LDR, brachytherapy, he had favorable intermediate risk disease, got the radioactive seeds, no hormone therapy.
Okay.
And his PSA over the last 6 months has risen from 0.9 to 1.6.
He almost doubled.
Right. But he has absolutely no symptoms. His DRE is completely unremarkable. Why am I not immediately ordering a scan for that guy?
Because that specific scenario is the textbook definition of the bounce trap. You have to look at the variables.
The timing is key, right?
The timing is everything. He is 14 months out from brachytherapy. That timing, usually between 12 and 24 months post-treatment, is the exact epicenter of the expected time frame for a benign inflammatory bounce.
And the magnitude of the rise.
The absolute magnitude is modest. He went up by 0.7 points. Plus, he is completely asymptomatic. If you order a PSMA PET scan in this moment, you are inviting disaster.
Let's walk through why a scan is actually harmful there. Because people think, well, a scan is just a picture. What's the harm? The PSMA PET uses a radiotracer that binds to the prostate-specific membrane antigen.
Correct. But here's the catch: PSMA expression isn't exclusively limited to prostate cancer cells.
Right.
It can be upregulated in benign prostatic tissue, particularly during states of active inflammation or tissue repair.
Which is exactly what's happening during a bounce.
Exactly. If you scan that 65-year-old at 14 months while he is having an inflammatory bounce, the prostate might show vague, nonspecific radiotracer uptake purely due to the ongoing immune response to the seeds.
So the scan lights up. The radiologist reads it as suspicious for local recurrence. The patient has a full-blown panic attack.
And you are backed into a corner where you have to do a highly morbid salvage biopsy on a recently irradiated prostate.
And you subjected him to all of that for a self-resolving inflammatory wave.
Yeah. The cheapest, safest, and most scientifically sound test for a possible bounce is time.
Time is a diagnostic test.
It really is. You sit down with the patient, you extensively counsel him about the bounce phenomenon, and you schedule a repeat PSA draw in 3 months. In a true bounce, the subsequent PSA will peak and then steadily drop back down as the inflammation subsides.
Okay, so we have patience for the early, small rises. But what if the trajectory is more concerning?
Give me a scenario.
What if we have a 70-year-old man who underwent definitive EBRT with ADT 4 years ago?
4 years, okay.
His nadir PSA was exactly 0.2. His testosterone is fully recovered. Over the past year, his PSA has slowly risen from 0.4 to 0.7, and today it is 1.4. He is perfectly fit and explicitly states he wants further treatment if the cancer is back.
Well, look at the math first. His nadir was 0.2. The Phoenix definition is nadir plus 2. So 0.2 plus 2 is 2.2. He is currently at 1.4. Strictly speaking, he has not crossed the Phoenix threshold for formal biochemical failure.
Right, but I would argue that waiting for him to hit 2.2 is a massive clinical mistake.
It absolutely is. The definitions are guidelines. They aren't suicide pacts. You have to treat the trajectory and the clinical context, not just the absolute number.
Let's analyze why his situation is so different from the brachytherapy bounce we just discussed.
First, the timing. He is 4 years out. That is well beyond the typical 12 to 24-month window for a benign inflammatory bounce.
And second, his testosterone.
Right. His testosterone has already fully recovered, meaning the sequential, relentless climb over a full year is not just his normal background tissue waking up.
Most importantly, he is fit, motivated, and a realistic candidate for a salvage intervention.
Yeah, if you tell him to come back in a year just so he can mathematically hit 2.2, you might miss the critical therapeutic window where his disease is still localized to the pelvis and potentially curable.
This is exactly where you obtain the PSMA PET scan and the prostate MRI, and you prepare for a biopsy if local salvage is on the table. You initiate an early clinical evaluation based on a highly concerning trajectory.
Let's pull this logic back to our main anchor case.
Yes, the 68-year-old.
Right. He is 2.5 years out from his radiation and his 6 months of ADT. His PSA went from undetectable during the hormone therapy up to zero point 0.4 6 months after his testosterone recovered, and today it is sitting at 1.6.
Okay, let's run him through the Phoenix math. His true nadir, the absolute lowest point his PSA reached during his entire treatment course, which was while he was on the ADT, was undetectable. Let's call it 0.
Okay.
So Phoenix requires a rise of nadir plus 2. He needs to hit a PSA of 2.0. Today, he is at 1.6. So technically, he does not meet the formal definition.
And this is where junior clinicians often try to play a dangerous mathematical trick.
Oh, I've seen that.
They will look at the chart and say, well, his nadir off of the ADT was 0.4. So if we use that as the baseline, 0.4 plus 2 is 2.4. We've plenty of time.
You cannot substitute an off ADT nadir to artificially change the math and buy yourself psychological comfort.
You absolutely cannot. The definition is based on the absolute nadir achieved during the entire treatment paradigm, period.
That brings us to the testosterone. I always say the testosterone level is the decoder ring for reading a post-ADT PSA.
I love that.
Attempting to interpret a post-ADT PSA without knowing the exact testosterone status is, honestly, clinical malpractice.
The mechanism here is fundamental to prostate cancer biology. Prostate-specific antigen is a protein driven directly by the androgen receptor.
Right.
When you put a man on ADT, you are administering a medication, typically an LHRH agonist or antagonist, that shuts down testosterone production at the testicular level. You are starving the prostate cells of their primary fuel.
And without testosterone binding to the androgen receptor, the cellular machinery that transcribes the PSA gene simply stops working.
Exactly. That is why his PSA fell to undetectable.
But now, his testosterone has recovered into the low normal range over the last 9 months. The fuel supply has been turned back on.
And when the fuel returns, the androgen receptors in whatever benign, healthy prostate tissue survive the radiation are stimulated again. They wake up and begin producing normal background levels of PSA.
Therefore, seeing his PSA go from undetectable to 0.4 after testosterone recovery is an entirely expected physiological response.
It is. It's a sign of his normal endocrine axis returning to function.
Going from 0.4 to 1.6, however, is a completely different story.
Yeah. That is a quadrupling of the value. It is sustained. It is beyond the typical bounce window since he is 2.5 years out. And he is a potential salvage candidate.
So we agree we are highly suspicious of a true recurrence. Let's say we get the PSMA PTT scan, and it shows a glowing, intensely avid spot right in the right peripheral zone of the prostate.
Okay.
No disease in the lymph nodes, no disease in the bones. It looks like an isolated local failure.
Well, if you are considering a local salvage therapy, like a salvage radical prostatectomy or cryoablation or high-intensity focused ultrasound, HIFU, you are facing a massive decision.
A huge decision.
And the absolute unbreakable rule of that decision is that imaging does not replace pathology. You must obtain biopsy confirmation of that local recurrence before you proceed with a salvage local treatment.
Let's really dig into the why here.
Yeah.
The PSMA PET is highly sensitive. The scan is glowing bright red, right where his initial tumor was. Why jump through the hoop of a transrectal or transperineal biopsy?
Because the morbidity of salvage local therapy is staggering. And PSMA PET scans, as good as they are, have limits to their spatial resolution.
Right.
The scan might accurately identify the macroscopic recurrence in the prostate, but it is entirely possible the scan is missing microscopic subclinical distant metastatic disease in a small pelvic lymph node or a distant bone.
And if you skip the biopsy, assume the glowing prostate is the only problem, and send him to the operating room for a salvage prostatectomy.
Right.
You are navigating hostile surgical territory.
It is an absolute nightmare for the urologist. The radiation has obliterated the normal fascial planes. The neurovascular bundles are heavily fibrosed.
And the plane between the posterior prostate and the anterior rectal wall, the fascia of Denon-Villiers, is often scarred solid.
The surgical dissection is brutal. The rates of severe permanent urinary incontinence due to damage to the external sphincter, the rates of catastrophic rectal injury, and the rates of anastomotic strictures are astronomically higher than in a primary upfront prostatectomy.
So you put this 68-year-old man through a grueling surgery. He loses his urinary control permanently, and then, 3 months later, his PSA starts rising again.
Exactly why the biopsy is so critical. His PSA rises because he actually had microscopic systemic disease all along. You subjected him to life-altering severe anatomical toxicity without actually solving the oncological problem.
The biopsy proves the active cancer is truly localized.
And furthermore, you must mandate that the urologist samples the seminal vesicles during that biopsy.
Why the seminal vesicle specifically?
Because if the disease has heavily invaded the seminal vesicles, a local ablative salvage therapy like cryotherapy is highly likely to fail. You have to map the exact extent of the local failure.
Makes total sense. And, when you were reviewing that PSMA PET scan with the radiologist, you have to read the imaging in specific anatomical basins in order of likelihood.
Yes, you cannot just stare at the whole body maximal intensity projection and let your eyes dart around.
You need a disciplined search pattern based on the biology of prostate cancer spread.
So Basin 1 is the primary site. After definitive radiation, local recurrence is usually hiding within the prostate itself, often right at the site of the original dominant intraprostatic lesion.
And if the patient had a prior prostatectomy?
Then you are looking at the prostate fossa, specifically the vesicourethral anastomosis, the posterior bladder neck, and the retrovesical region.
Okay, once you clear Basin 1, you move to Basin 2, the pelvic lymph nodes. We were looking at the primary lymphatic drainage pathways of the prostate.
Right. The obturator nodes, the external iliacs, and the internal iliacs.
Basin 3 is the skeletal system. Prostate cancer has a profound osteotropic predilection. It loves to metastasize to the bone marrow.
So you are scrutinizing the axial skeleton, the lumbar and thoracic spine, the pelvic bones, the sacrum, and the ribs.
And finally, Basin 4 is the visceral organs, the lungs and the liver.
Visceral metastases are much rarer in prostate cancer. They usually represent late-stage castration-resistant disease with dedifferentiated biology, but you still must check them.
Reading the scan in that strict order, prostate or fossa, nodes, bone, viscera, prevents you from getting distracted by a blurry, equivocal spot on a rib while missing a massive local recurrence right at the bladder neck.
It's all about discipline. But let's pivot back to the patient in the room.
Right.
We have spent an extensive amount of time dissecting his PSA chart, his testosterone axis, and the recurrence workup. But he is physically sitting there telling you he's bleeding from his rectum 2 or 3 times a week.
Yeah.
Before we discuss how to treat that late toxicity, what is the mandatory first step?
The mandatory first step is to pull up his original radiation treatment plan from 2.5 years ago. That prior plan is not optional background rating. It is the exact blueprint of his current pelvic anatomy. You cannot just look at the summary printout. You have to open the planning software, look at the axial dose distribution, and physically scroll through the CT slices.
You need to see exactly where the high-dose region intersected with the anterior rectal wall, the bladder neck, the urethra, and the penile bulb.
Because this is where we need to explain the inherent limitations of the dose volume histogram, the DVH.
I see clinicians glance at the DVH and say, well, the V70 of the rectum, meaning the volume of the rectum that received 70 gray or more, was within our institutional tolerance limits, so the bleeding must be from something else.
The DVH is nothing more than a one-dimensional mathematical summary. It tells you the total volume of an organ that received a certain dose, but it completely strips away the spatial reality of where that dose was deposited.
Imagine 2 completely different radiation plans. In Plan A, the high dose is spread out thinly over a large, broad area of the rectal mucosa. In Plan B, that exact same volume of high dose is concentrated into one tiny, intense spherical hotspot right on the anterior rectal wall at the level of the midgland.
The DVH for both plans might look mathematically identical.
Exactly. But the patient with Plan B is the one sitting in your clinic bleeding 2 years later because that concentrated hotspot caused severe local tissue breakdown. You have to evaluate the shape, location, and intensity of the hotspot.
Let's go deep into the pathophysiology of late radiation proctitis. Why is he bleeding now, 2.5 years after the radiation stopped?
It is a fundamentally different process than acute radiation toxicity. Acute toxicity during the treatment is just mucosal sloughing and acute inflammation.
Right.
But late radiation toxicity is driven by chronic, progressive changes to the microvasculature. The radiation causes profound DNA double-strand breaks in the endothelial cells lining the tiny blood vessels in the rectal wall.
And over months and years, these endothelial cells undergo apoptosis.
Yes. You get a massive upregulation of transforming growth factor beta, TGF-beta, which drives a relentless cascade of fibrosis.
So the tissue is becoming scarred, stiff, and most importantly, hypoxic. The normal blood supply is obliterated.
The rectal wall literally becomes ischemic, and the body, sensing this lack of oxygen, attempts to heal the area by triggering angiogenesis, the formation of new blood vessels.
But because the tissue matrix is severely fibrotic and damaged, these new vessels are abnormal.
Very abnormal. They are thin-walled, fragile, tortuous telangiectasias. They lie right near the surface of the mucosa.
So when normal, firm stool passes over these fragile neovessels, the sheer mechanical friction causes them to tear and bleed.
That is the bright red blood he's seeing in the toilet bowl.
How do you counsel him in that moment? I mean, he sees blood in his stool. He has a history of cancer. His immediate internal narrative is that the cancer has spread to his bowels.
You start with the direct empathetic reassurance. You explicitly explain the mechanism of the fragile blood vessels we just discussed. You validate that this is a known, expected late side effect of the prostate radiation he received, and that it is usually highly manageable.
But there is a massive caveat here. Having had pelvic radiation does not grant a patient magical immunity from every other gastrointestinal disease on the planet.
It is a critical diagnostic trap. He can still develop internal hemorrhoids. He can still develop inflammatory bowel disease like ulcerative colitis or Crohn's.
And most terrifyingly, he can still develop a second primary malignancy, like an aggressive colon cancer or a radiation-induced rectal sarcoma.
Right. If his bleeding pattern changes from bright red blood on the tissue to dark, tarry stools, or if he develops abdominal cramping, unexplained weight loss, or profound iron deficiency anemia, you must immediately refer him to gastroenterology for a full colonoscopy.
You cannot blindly assume every drop of blood in a radiated pelvis is just proctitis.
Never assume that.
So once we have reassured him and ruled out the red flags, we have to actually stop the bleeding. There is a stepwise escalation ladder for managing radiation proctitis.
Let's hear it.
The mnemonic is CSEH. Conservative steps, avoid hyperbaric. Let's walk the rungs of that ladder.
So the first rung is C for conservative management. This directly targets the mechanical trauma component. You want to avoid firm stool shearing those fragile telangiectasias.
So you aggressively implement bowel regulation.
You prescribe daily osmotic stool softeners, encourage high dietary fiber intake, and ensure robust oral hydration. The goal is soft, formed stool that passes smoothly without any straining.
And for a vast majority of mild cases, this simple mechanical intervention is entirely sufficient to stop the bleeding.
But let's say he is fully compliant with the regimen. His stools are soft, but the intermittent bleeding persists. We escalate to the S rung.
S stands for sucralfate enemas. Sucralfate is a basic aluminum salt of sucrose sulfate.
Right. And in the acidic environment of the ulcerated mucosa, it polymerizes and forms a viscous, sticky paste that aggressively binds to the exposed proteins of the damaged tissue.
So delivering it directly to the anterior rectum via a retention enema creates a physical protective coating over the bleeding vessels.
It essentially acts as a localized mucosal bandage, soothing the lining and allowing the microvasculature a chance to stabilize without constant exposure to fecal matter.
Now suppose the bleeding is worsening, yet it's becoming clinically meaningful. His hemoglobin has dropped from 14 to 11. The sucralfate isn't holding it back. We need to escalate to the A rung.
A is for argon plasma coagulation, or APC. This is where we involve our gastroenterology colleagues.
What exactly does APC do?
APC is an endoscopic thermal ablation technique. The GI doctor inserts a flexible sigmoidoscope and visualizes the bleeding telangiectasias. They then use a probe that emits ionized argon gas to conduct a high-frequency electrical current directly to the fragile vessels.
The beauty of APC is the depth of penetration, isn't it?
Precisely. It cauterizes the bleeding vessels superficially, usually only 1 to 3 millimeters deep.
This is crucial because if you use deeper thermal coagulation devices, like a standard ND.YAG laser, in a previously radiated hypoxic thin rectal wall, you risk causing full-thickness necrosis,
which leads to a catastrophic rectourethral fistula or a rectal perforation. APC provides excellent hemostasis with a very favorable safety profile for radiated tissue.
And finally, we reach the top rung of the ladder, reserved for severe, refractory, hemorrhagic radiation proctitis that is resistant to multiple rounds of APC, the H rung.
H is for hyperbaric oxygen therapy, or HBO. This is a profound systemic intervention. If the patient has widespread severe ischemic damage to the rectum, we place them in a hyperbaric chamber.
They breathe 100% pure oxygen at pressures, equivalent to 2 or 2.5 times normal atmospheric pressure.
Right.
Explain the physics and biology of why that works. I mean, we aren't just giving them a nasal cannula.
The physics relies on Henry's law, which states that the amount of gas dissolved in a liquid is proportional to its partial pressure above the liquid.
No.
By breathing pure oxygen under massive pressure, we dissolve huge quantities of oxygen directly into the blood plasma, bypassing the hemoglobin carrying capacity entirely. This supersaturated blood circulates down into the pelvis and forces oxygen deep into the severely hypoxic, fibrotic, radiated rectal tissues.
And what does that sudden influx of oxygen do at the cellular level?
It fundamentally breaks the fibrotrophic cycle we talked about earlier.
Yeah.
The high tissue oxygen tension stimulates macrophages to secrete angiogenesis factors.
It promotes the proliferation of fibroblasts and the massive synthesis of new collagen.
It literally drives the growth of healthy, robust, functional new capillary networks. You are permanently repairing the microvasculature from the inside out rather than just cauterizing the surface.
In a massive time commitment, though, often 30 to 40 daily sessions.
It is, but for truly refractory cases, it is frequently the only thing that prevents a permanent diverting colostomy.
So, conservative steps. Avoid hyperbaric. CSAH. Now, proctitis is the major GI toxicity, but we also have to evaluate late genitourinary, or GU, toxicity.
After external beam radiation, late GU toxicity is heavily weighted toward irritative and obstructive symptoms. The detrusor muscle of the bladder can become fibrotic, leading to decreased bladder compliance.
You see profound urinary frequency, intense urgency, and nocturia waking up multiple times a night to void, which just shatters their sleep quality.
You can also see late radiation cystitis, where the fragile mucosal vessels of the bladder bleed, causing gross hematuria.
And we occasionally see urethral strictures, which is a fibrous narrowing of the urethral lumen, often near the bulbomembranous junction where the dose gradient is sharpest.
Right.
What about brachytherapy? The toxicity profile there has a distinct signature, doesn't it?
Brachytherapy is a completely different physical dose delivery. Because the radioactive seeds are implanted directly into the prostate stroma, the intraprostatic dose is astronomically high.
So in the acute setting, right after the implant, the physical trauma of the needles and the intense radiation cause immense prostatic edema.
The gland swells dramatically, and acute urinary retention, the sudden, agonizing inability to urinate requiring an emergency catheter, is a major risk.
And in the late setting, years down the line.
Years later, brachytherapy patients have a statistically higher risk of persistent, severe irritative voiding symptoms and dense urethral strictures compared to those who received standard external beam radiation.
Furthermore, in certain high-dose contexts, or if brachytherapy is used inappropriately as a salvage therapy after previous external beam radiation, there is a small but truly devastating risk of erectourethral fistula.
This is where the tissue between the prostate and the rectum completely breaks down and urine freely flows into the rectum while stool passes into the urethra. It is a surgical nightmare.
Which perfectly illustrates why we were so emphatic about the dangers of salvage local therapies earlier.
Yeah.
You cannot view a previously radiated pelvis as normal surgical territory.
Never. Now let's pivot to the third and, frankly, the most neglected job of follow-up. We have addressed the cancer scare with the PSA trajectory. We have exhaustively addressed the rectal bleeding toxicity. But the urology note that triggered this entire visit completely ignored the metabolic bomb that detonated in this patient's body over the last 2.5 years.
I know exactly what you're talking about.
I am talking about the systemic consequences of the androgen deprivation therapy.
The forgotten job. ADT survivorship is where the medical system consistently fails these men.
It really is.
It is often treated as an optional checklist item if you happen to have 5 extra minutes at the end of the clinic encounter. That mindset has to end. Survivorship is a fundamental, integral, inseparable part of the comprehensive treatment plan.
If you wrote the prescription for the LHRH agonist, you own the systemic consequences of that chemical castration.
Let's dissect the domains of ADT toxicity, because the loss of testosterone affects virtually every major organ system in the male body. We have to start with the skeleton.
Testosterone and its conversion to estrogen via aromatase is absolutely critical for maintaining bone mineral density in men.
It regulates the balance between osteoblasts, which build new bone, and osteoclasts, which resorb old bone.
And when you remove testosterone from the equation, you cause a massive, rapid uncoupling of that system. Osteoclast activity surges, vastly outpacing osteoblast activity.
The bone is broken down faster than it can be repaired.
This leads to accelerated bone mineral density loss, rapidly progressing through osteopenia to frank osteoporosis.
This significantly increases the risk of clinical fragility fractures, particularly in the femoral neck of the hips and the vertebral bodies of the spine. A hip fracture in a 75-year-old man carries a massive mortality risk.
Beyond the skeleton, ADT fundamentally alters their metabolism and body composition.
The physical transformation is profound.
Patients experience severe sarcopenia, which is the rapid loss of lean skeletal muscle mass. Simultaneously, they experience a dramatic increase in visceral adiposity fat deposition around the internal organs.
They gain weight, but it is entirely the wrong kind of weight.
Let's trace how that sarcopenic obesity drives systemic metabolic disease. Skeletal muscle is the primary sink for glucose disposal in the body. When you lose that muscle mass and simultaneously increase visceral fat, which is highly metabolically active and secretes inflammatory adipokines, you directly trigger peripheral insulin resistance.
The cells stop responding efficiently to insulin.
Their glycemic control completely deranges. Men who had totally normal blood sugars can be pushed into prediabetes, and men who are prediabetic can be pushed into frank, uncontrolled type 2 diabetes within months of starting ADT.
The cardiovascular implications of that metabolic shift are terrifying.
The lipid profiles become highly atherogenic. You see a significant elevation in serum triglycerides and LDL cholesterol, while the protective HDL cholesterol remains stagnant or drops.
So when you combine the worsening lipid profile with the new onset insulin resistance, the central weight gain, and the loss of lean muscle, their overall cardiovascular risk profile absolutely skyrockets.
This is why a radiation oncologist must coordinate aggressively with the patient's primary care physician or cardiologist. You have to monitor their blood pressure, their lipid panels, and their hemoglobin A1C.
Then there are the profound quality of life domains that patients rarely, if ever, bring up voluntarily.
Sexual dysfunction is virtually universal. We are talking about a complete loss of libido, profound erectile dysfunction, and actual structural changes, including penile shortening and testicular atrophy.
Additionally, there are severe neurocognitive and mood effects.
The sudden loss of testosterone causes significant emotional lability, clinical depression, massive fatigue that isn't relieved by sleep, and intense vasomotor symptoms.
The hot flashes.
Yes, hot flashes that can occur 10, 15 times a day, completely destroying their sleep architecture and leaving them exhausted.
So how do we actionably manage this immense burden of toxicity?
The required paradigm shift is moving from reactive observation to aggressive, proactive management. Let's look at a clinical scenario to illustrate this.
Okay, let's say you have a 68-year-old man sitting in your clinic.
Yeah.
You are about to start him on 24 months of continuous ADT combined with EBRT for locally advanced high-risk prostate cancer.
Right.
While taking his history, you note he has baseline hypertension and a strong family history of osteoporosis and hip fractures.
His survivorship framework must be exhaustive, and it must be initiated today, not 6 months from now when he complains of weakness.
Right.
Because he is committing to a long-course, 2-year ADT regimen, and he already possesses massive baseline cardiovascular and skeletal risk factors, I am building the armor before the battle starts. I am ordering a baseline DEXA scan, a dual-energy X-ray absorptiometry scan today to precisely quantify his bone mineral density.
And if that DEXA scan comes back showing he already has osteopenia, what is the intervention?
I am immediately starting him on bone protective agents. This could be an oral bisphosphonate like alendronate, which directly inhibits osteoclast-mediated bone resorption.
Or a rank ligand inhibitor like denosumab, which blocks the maturation and function of osteoclasts.
Exactly. I am also starting him on heavy calcium and vitamin D supplementation today.
What about the metabolic and cardiovascular side?
I am explicitly writing a prescription for resistance and weight-bearing exercise, not just telling him to stay active, but a formal physical therapy referral for supervised resistance training to combat the sarcopenia.
Nice.
And I am communicating directly with his primary care physician to hypermanage his blood pressure, track his lipid panels every 6 months, and closely monitor his A1C.
And for the sexual health and vasomotor symptoms.
Here is a critical piece of clinical advice. You must ask the specific, direct questions. Are you experiencing hot flashes? How severe are they? Are you able to achieve erections? Has your sexual desire disappeared?
Because patients feel immense shame and embarrassment around these side effects. They feel stripped of their masculinity.
They will almost never volunteer the information unless you normalize it and create a safe clinical space for the discussion. If the hot flashes are unbearable, we can intervene with medications like venlafaxine or gabapentin.
The guiding principle here is powerful. Treat the cancer, but do not create a second untreated disease in the process.
That's it right there.
Curing a man of a high-risk prostate adenocarcinoma only to have him die of a massive myocardial infarction 4 years later because you completely ignored his skyrocketing lipids, central obesity, and severe insulin resistance is a profound failure of comprehensive oncology care.
Well, we have covered an immense amount of clinical ground today. We have dissected the Astro and Phoenix definitions, the immune biology of the PSA bounce.
The critical mandate for biopsy before salvage therapy, the cellular mechanisms of late proctitis, and the sprawling systemic impact of ADT.
Let's bring all of these threads together into a unified clinical philosophy. We have established that prostate cancer follow-up is not merely a task of checking a blood value. It is a comprehensive philosophy of care built on distinct pillars.
You have to accurately detect true oncologic recurrence while having the discipline to avoid the trap of the inflammatory bounce.
You have to actively hunt for, understand the mechanism of, and manage late toxicities like fragile rectal neovasculature.
And you must take absolute proactive ownership of the metabolic, skeletal, and psychological survivorship of the patient.
The clinician who reacts to every single minor PSA wiggle with an expensive PET scan, but never once asks their patient about their bone density trajectory, their cardiovascular risk factors, or their sexual function, has completely inverted the true priorities of survivorship.
Well said. I want to leave you with one final thought regarding the future of this entire follow-up paradigm. We've spent this whole session agonizing over the nuances of PSA bounces, the Phoenix definition, and testosterone recovery.
Right.
But what if the entire concept of tracking the PSA protein is fundamentally obsolete?
It is a fascinating horizon. We are rapidly approaching an era where liquid biopsies and circulating tumor DNA, ctDNA, might completely replace the PSA blood draw.
Imagine a follow-up visit where, instead of trying to guess if a 0.7 rise is an inflammatory bounce from a brachytherapy seed or a true macroscopic recurrence, we simply draw blood and sequence it for the exact epigenetic methylation signatures and genomic mutations of the patient's original tumor.
If the ctDNA is negative, the cancer is gone, regardless of what the normal prostate tissue is doing. The anxiety of the PSA bounce would vanish overnight.
The ambiguity of the Phoenix definition would become a historical footnote. We wouldn't be tracking a proxy protein, we would be tracking the actual tumor genome in real time. It completely redefines what early detection in the salvage setting actually means.
But until that day arrives, we must master the tools we have. Trajectory over absolute numbers, context over panic, and complete ownership of the patient's survivorship.
Complete practice oral boards at radongsmartlearn.com and subscribe to Radong Smart Review for our next episode. Thanks for tuning in.